Hello. Bedu. Inside the equation. बड़ा करना है. Yeah. The screen share. Should I go for the screen share?
I'll just introduce you first, sir. A very good morning to all distinguished colleagues. I'm Dr. Samir Muchala, heading the medical affairs for the cardiodiabetology therapy areas at Zydus Healthcare Limited. At the outset, I'm sure you and your loved ones must be safe and healthy during this current trying times. It gives us immense pleasure today to invite each one of you to our live webinar on RAAS inhibition in hypertension, focus on guidelines and target organ damage. Hypertension has been defined by WHO as one of the most important risk factors for cardiovascular mortality and morbidity. It has been intricately related with the development of complications like ischemic heart disease, heart failure, stroke, and chronic kidney disease. An estimated 57% of stroke-related deaths and 24% of coronary artery disease-related deaths are attributed to hypertension. RAAS inhibition has been the most commonly used avenue in daily practice today in treating hypertension. These agents are endorsed by guidelines, Indian or global, and also have beneficial effects on hypertension-mediated target organ damage. To enlighten us more today evening, it is my honor and privilege to introduce our speaker for the evening, Dr. Shishu Shankar Mishra. Dr. S.S. Mishra is Professor and Director, Department of Cardiology, High-Tech Medical College and Hospital, Bhubaneswar. He's a Director and Consultant Cardiologist at the Med and Heart Clinic, Cuttack. He's Vice President, ICC, and ex-Executive Member and Joint Secretary, CSI. I welcome Dr. Shishu Shankar Mishra to today's webinar and request him to take the scientific proceedings forward. Thank you.
Thank you, Samir. Thank you for the nice introduction. So, friends, it's a great pleasure in the evening to be with you in the webinar. Though we are supposed to make a handshake and meet each other, this COVID-19 guideline has separated us physically. So let us be together today evening mentally and socially through the webinar and the lines rather than through the physical contacts. Samir, I am audible? Okay. So with this background, let us talk about a little about the hypertension, which is the talk of the day. A small brief introduction has already been given by Samir about its importance. And let me proceed further that how RAAS inhibition is important in hypertension with the background of the focus and the guidelines are present and the target organ damage and its prevention with this RAAS inhibition. So, friends, we have started the journey of knowing that there is a pressure in the arteries with Reb Stephen cells way back in 1761. He could put a 8 feet 3 inches water column to measure this pressure in, say, horse. This is where we could know that there is a pressure in the arterial system. Then with the discovery of Riva-Rossi, the sphygmomanometer, we thought of measuring it. And in 1931, how we viewed that the hypertension is still interesting, that the biggest danger is in high blood discovery of the high blood pressure is because if it is discovered by some fool, they will try to reduce it. It was
told by slides are not visible. Have you started sharing your slides? Because
yes. It is.
Jignesh, is it visible to you? It's not visible to me.
Oh, sir. Sir has to stay.
Is it there by now? I have said it.
No, we cannot see your slides, sir.
Okay, then how to, slides are not visible.
Can you just click on slide share?
Okay, I'll go back again. Slide share, yes, slide share screen. Share. Yes,
Yeah,
now it is visible.
Yeah, now it's visible. Perfect.
अरे ये कहीं चालू नहीं देख लो. Oh,
Now it's visible.
okay, just a minute.
Sure.
Now it's going up and down. Fine.
Yeah.
So this is, I think I have told you, it was audible about this Stephen Hells, about the 8-feet water column to discover the pressure in the arterial head. Then with the Rivarosi, the sphygmomanometer. And with that discovery in Hay in 1931 commented the biggest danger in high blood pressure lies in its discovery or measurement, because some fool will try to reduce it one day. This was the concept that that is why it was called essential or benign hypertension in those days. And these are interesting stalwarts who died of hypertension almost without treatment: Churchill, Roosevelt, and Statin. And in 1945, at the Volta, after the convention, Churchill, Roosevelt, all were together. In that year, Roosevelt died of hypertension, who was treated with simple rice, distilled water, and cooked rice. We had no concept at that time what to give and what not to give. And all the concept grown in last 70, 75 years where we stand today. With that, the hypertension is a major modifiable risk factor for premature cardiovascular diseases and stroke globally. That is why it is very, very important, and it is a silent killer, because hypertension almost never causes much of symptoms. The effective control of blood pressure can bring down the disastrous consequences of hypertension to a greater extent. And RAAS receptor blockers, or the ARBs, are emerging as an attractive choice in the contemporary times, along with the ACEI, the CCB, diuretics, and other bunch of drugs. The prevalence of hypertension is very significant. You see, globally is around, say, 49% of the population, and the treatment is control is very low. In 17, it was 16%. By the time JNC 8 they discovered, JNC 9 though not well found, still in 59% people have been told to have some amount of control. That is in 2017 guidelines. And the prevalence of the Indians are equally important. You see, Krishna and all of the country CSI members had conducted a one-day study. A large number of people, from which the study showed that there is a spectrum of blood pressure incidence. Even in the youngest person, that is in 18 to 19, there are around 16%, and around every alternate person, that is 52% in elderly people more than 75, and a average of around 34% in the whole population, means around 40%, 40 crores of people in India are suffering from hypertension, and many of them are undetected. And in the urban, there are 33%, rural around 25%. 25% rural and 42% urban Indians are aware that they have about hypertension, because it is a silent killer, no symptoms. Many people do not know they are suffering from hypertension. It is the clarion call of the day to detect and treat these people. And around 57% of these people die of strokes, and 24% are the impact of coronary artery disease, rest almost from the kidney failure and other consequences of the HMOD. And to treat this, in the last 75 years, a lot of concept came, how much we have to reduce the blood pressure, what is the ideal blood pressure. You see, JNC 1 to 7 was very popular in the process that we used the guidelines very popularly, and JNC 8 it got diluted, and after that, lot of individual associations have come up with a lot of guidelines starting from ACC, AHA, so many Canadian guidelines, Australian guidelines, Indian guidelines. But whatever it may be, friends, hypertension is not a number, but a systemic disease. It should be managed to address all the target organs, not the number, and also the vascular biology as a whole. In that context, I give you two model examples that the ESS European people are still conservative, and it's the same thing also in 2020. The International Hypertension Society also have a similar thing, that optimal is less than 120, normal is around 120 to 29, and high normal is 130 to 139, grade 1 40 to 60, grade 2 62, and grade 3 is around more than 103. Similar is the Indian concept, and isolated is more than 140 and less than 90 is the diastolic. These people in American hypertension, they modified with the impact of the sprint trial. They came down, the normal is less than 120 and diastolic 80. Elevated means which was a high normal with the other guidelines, it became elevated blood pressure. New concept they have put 120 to 130. And by the time 130 to 139, which was high normal, is a class stage 1 hypertension, which is to address and treat it. And stage 2 is more than 140 and above, and diastolic above 90. So what are the basic differences in the two concepts is about the when to start the treatment. You see, definition of hypertension more than 130 with the AHA, and ESC more than 140 by 90 with the International Society also in 2020 also agrees with that. They use the score system, and with the CKD, you see it is less than 130 and it is 140 with the ESC. And monotherapy is start with the ACEI guidelines with the stage 1 means it is 130 to 140. Start two drugs combination is the ideal things with the European concepts. So BP targets and all these things at the lower border has changed with the sprint effect. And this is the Indian classification, which is almost similar. We have stage 1, grade 1 and grade 2 isolated hypertension 140 to 160 and less than more than 140 stage 2. Otherwise, it is the same thing like that. And the burden of the hypertension globally has increased, and around 57% have stroke and 24 of the CVD. And there is a clarion call today that we should be alert about it as physicians at all levels to treat hypertension. This is what I was telling you about the International Hypertension Society 2020. It is less than 30 is their normal. Grade 1, grade 2 remains as I have already discussed. They have highlighted about the measurement protocol. All of you go through this in detail. The sitting position, cool down, no coffee, no walking, no talking, all these things, and use a good validated electronic or a manual auscultatory method. And the auscultation modality about the carrot cup protocol has been well described by the AHA latest guideline. So just to remind you, hypertension around 93 to 95% are essential, means we don't exactly identify a treatable focus, but you have to treat it throughout the life of the hypertension. The other causes could be renal and the renovascular 1 to 2%. Pheochromocytoma, primary aldosteronism causing around 0.3%. Oral contraceptive, this is a growing problem with the modern ladies around 0.5%. So screening has to be done always for the, if it is less than 120 by 80, you can see every 3 to 5 years. And if it is between 130, 20 to 130 and 80 to 84, every 3 years. And if it is 130 to 140, consider if it is a masked hypertension, if there is some target organ damage, and repeat the test frequently. Once it is more than 140, then use to confirm the diagnosis for repeated visits. And once you established either by the office measurements or ambulatory or home blood pressure monitoring, then finalized that the patient is to be treated if it is more than 140 by 90. So a patient with where we can use a SVP or ABP is very important. In all patients where grade 1 hypertension, we are not able to decide, or the office BP is fluctuating, or there is a maxed hypertension suspicion with a or target organ damage, or the hypertension mediated organ damage is suspected, or there is a postural or postprandial hypotension with the treated or untreated patients, or patient with is considerable variable in blood pressure. In those, you can go for a 24 hours ambulatory blood pressure or frequent home measurements. So the advantage of the ambulatory blood pressure, it covers 24 even during sleeping and during walking, but it is expensive and uncomfortable. But with home monitoring, it is easy, it is cheap, it can be repeated by the person in the house once little trained with the digital type of blood pressure measurement. Then you have to assess the hypertension related target organ damage, which is very important. A 12-lead ECG is mandatory. Urinary albumin and creatinine ratio is always important. Creatinine with the eGFR, endoscopy, echocardiography, carotid ultrasound for the intima media thickness, the abdominal ultrasound and the Doppler for the renal studies, the pulse wave velocity, the ABI for the peripheral vascular damage, cognitive function studies has to be done in each person at once they're becoming elderly, and brain imaging has to be done with CT scan and other modalities available. So once the patient is already in high blood pressure between 130 to 140 means high normal, lifestyle modification is there, but by American Association guidelines, you can start a drug also here. And with the grade 1, you like in all grades, the lifestyle is common. That has to be mandatory. And once it is grade 1, you start the lifestyle and add one drug and see if it is not controlled, for go for subsequent drugs and review every 1 to 3 months regularly. Same thing also in grade 2, go for 2 drugs or as required. And same thing also in grade 3, immediately go for a combination drug and reduce the blood pressure within 2 to 3 months. So what are the first thing important is a lifestyle modification that we have been talking. So you have to, if somebody is obese, reduce the BMI less than 25. For Indians, it is less than 23. Reduce the salt intake less than 6 grams. Use a DASH type of diet. All of you know about the diet is rich in fruits, vegetables, low fat, and reduced saturated fat. Alcohol moderation consumption has to be taken, but for Indians, this is already high risk. So Salim Yusuf has shown that there is some benefit. Physical activity has to be done at least 30 minutes a day or 150 minutes per week, brisk walking and other modalities of exercise. Friends, to draw your attention, is hypertension is just a number. It is also an inflammatory disease. This is associated HSCRP, and the PAI is also increased in significantly in many patients. You can study the intima media thickness, the carotid study, or the flow mediated vasodilation or the elasticity of your arteries. Again, coming to the RAAS and receptor blockers, you see the renin can be blocked from angiotensin to angiotensin 1, the ACE inhibitor from angiotensin to angiotensin 2. This angiotensin 2 is the worst molecule, that is otherwise called as the molecular murderer. And it works on the 4 sites, 81, 82, 83, and 84. 81 is the major pathway. 82 is the point of discussion in the COVID era, but we don't know the exact things, but it is told to be vasodilatory and protective. It is augmented, there is nothing wrong. And this is augmented by the so-called COVID virus as has been proposed by some people. So what are the RAAS modulators? Direct aliskirenin and the ACE inhibitors, all the pre-LC were all augmented starting from amipil to perindopril. And this angiotensin receptor blockers starting from losartan, valsartan, candesartan, irbesartan, telmisartan, olmesartan, and newer one is the azilsartan. All of these things are today used for our clinical practice, and combination therapy is the modality. This is the common pattern that you are already acquainted, but the combination with the angiotensin receptor and ACE inhibitor is often used rather more harmful in relation to side effects. So with younger age people, the AB means the beta blocker was earlier used, which has gone down. This is diuretic, and this is the calcium channel blocker for the old people. That stands. And in uncomplicated hypertension, this is one guideline. The initial therapy can be ACEI or ARB alone, or then you can combine with ACCB, then with a diuretic. This in stage 2, you can add all these 3 drugs. In stage 3, add all these 3 drugs in addition if it is resistant to spironolactone, further diuretics, alpha blocker or beta blocker as required. And in special situation, you can also use beta blockers. In hypertension with CAD, with the same protocol, you can add beta blockers as in the first line, because that is indicated for the acute myocardial infarction or CAD and the related problems. And the same thing happens when we go for the CKD or the chronic renal disease. Start with ACI and CCB, but you have to be watchful about the potassium level always and the urea and creatinine level. Same protocol has to be done, and this has to be used. And beta blocker also finds a place when heart failure, angina, and atrial fibrillation are there, or younger women are there. But, or when we avoid ACE inhibitors, particularly in a pregnant situation. With HFrEF, you see, with reduced ejection fraction, ACEI, ARB, and the beta blocker is very useful initial therapy. Then you go for stage 2, you add along with the dietary, MRA can also be added, but monitor always the potassium level. Same thing with atrial fibrillation, beta blocker is from the stage to the initial stage, and you can use a non-DSP CCB like verapamil or deltagen, but when you combine with a beta blocker, you have to be very careful and monitor the heart rate always. And you using the chart score, always add an anticoagulant as required. When you go to anti-hypertensive treatment in diabetes, you have to optimize that the blood pressure goes below down less than 140/90. Even less than 130/120 is still beautiful, and very good for the purpose of protecting HMAD. And when you are reducing the diastolic blood pressure, should be less than 80, but should not be less than 70. And the recommendation is to start with a RAAS blocker, then add for a CCB or a thiazide, but not combining 2 RAAS blockers. So what is the threshold of the treatment when you start? You see, that has already been again highlighted from 18 to 65, 140 systolic, diastolic 95, 65 to 79, 140, 140, 95, 90 in diastole. 80 years, here you have to be cautious that the target should be 160, means 140 to 160 at 8 years can be a manageable thing, but if the patient tolerates, you can reduce it further even to 140 or less. So what is important is how the patient is tolerating to your drugs. This is how the important is how you are reducing. When you are reducing, the systole should not be less than 120 in CAD or CKD or with the TIA patient. But this thing has been recently defined by the sprint trial, because this showed if it is less than 120, still there is significant benefit. And in the diastolic office should be less than 72. 79 means 80, all areas. You should be conscious about that. In Indian hypertension 13, we thought about beta blocker in the first line. These have been modified in 2019. If only ACE inhibitors, if not comfortable, add a CCB or a diuretic. In step 2, the same thing, ACD together. And in step 3, A plus C plus D. In the 4th stage, you can add a MRA like spironolactone and other drugs. Stage 5 with a alpha blocker and other drugs as desired. So we have to modify. This is the Indian scenario that has been studied by this. So recollecting back about the RAAS inhibition, what benefit we can get is ACE inhibition inhibits the angiotensin 2 blocker, and through the AT1 receptor, ACE inhibitor remains associated with cough. That is one of the very disturbing agent. That is why the risk is higher with the ACE inhibitors compared to ARBs. This is what is the site when ACE inhibitor blocks the ACE inhibition. The bradykinin is spared. And bradykinin has some advantages, like it increases nitric oxide fibrinolysis, but the cough is very much disturbing. And this is blocked by the ARB. And but ARB also stimulates, uh, behaves otherwise with the AT2 blockers. That is what is important in the COVID times. And ACEI and ARB in hypertension, if the three things are taken, ARB is showing better promising compared to the other two, SC inhibition or DRI, total inhibition. And reduction with the ambulatory BP, it has been seen 24 hours. The hypertensive burden of 24 hours is significantly reduced better with ARBs compared to even the SC inhibitors and beta blocker or calcium antagonist or diuretics alone. When the drugs are compared about the half-life, Telmisartan is a wonderful drug. Its half-life is around 24 hours. Next is Irbesartan, next is Olmesartan, Valsartan, and these drugs are also promising in a proper perspective. And Telmisartan has a PPRI gamma actions, which has an advantage for diabetes, and Telmisartan reduces the insulin resistance and the insulin sensitivity. So that the PG, PGI, and the HOMA-IR, everything, HbA1c, everything is reduced. That is a supportive treatment. And with ONTARGET, what we have learned with is a large, more than 25,000 patients have been taken. The comparison between Telmisartan and the Ramipril, which is excellent drugs after the HOPE study. And it has been found that the Ramipril and Telmisartan, and in combination, Telmisartan is no inferior. It is an excellent drug in its efficiency. Combination gives no additional advantage. So Telmisartan is effective as Ramipril in CV protection in high-risk patients, and Telmisartan is effective in reducing all different CV risks, including hospitalization, death, cardiovascular mortality, infection, everything is reduced. So far as adverse effects are concerned, with Telmisartan, it is significantly less compared to Ramipril. And with a meta-analysis in a relation to proteinuria, it has an advantage with the Telmisartan, and compared to proteinuria is 14% reduction more compared to the ACEI therapy. When you look at the Amlodipine combination or alone, Amlodipine when given alone, the efferent is not dilated, only afferent is dilated, so interglomerular pressure is increased. So we get the advantage of this benefit of the renal protection by combining Amlodipine along with Telmisartan. So Telmisartan and NRP was also combined in another study, that is the detailed study, in which the GFR and the changes in GFR are well protected. The nephroprotection is better. The preservation of the GFR is better with the Telmisartan group. With these classical studies like renal and the identity and detail, we found the renal protection is the preservation or the loss of GFR is still much less with the detailed study with Telmisartan. Comparison of ARB for diabetic hypertension in nephropathy, the comparison between all these two statins and two statins and two losartan, it has been found that it is more effective. Telmisartan is more effective compared to the other statins. And the urinary proteinuria is also less. And there are two studies in relation. One study about the Indian study about the LVH regression comparing with the atenolol. The LV mass is reduced almost around 27.5 times compared to 9.7 times reduction in the LVH regression. So in Telmisartan is better so far as LV mass index reduction compared to beta blockers. Telmisartan is established in CVD and high-risk patients. So far as beneficial is concerned, it was two large studies, 20,000 and 5,000, more than 5,000 with the transit and PROPHES study. With the endpoint, it has been found that the CV death, stroke, and hospitalization rate significantly reduced in both. And so far as endothelial function study in PCI patient, With earlier in 92, with BANIP study, it was shown that there is benefit with the benazepril. Similar thing was found that with the DES, which is the trend of the day to in myocardial infarction to put the DES, it has been found in 51 patients that the endothelial function has improved after using telmisartan. And the similar results also was found in BMS bare metal stents after using telmisartan. The instant thrombosis also is reduced, and the new intimal proliferation is significantly reduced. The need for combination therapy today has come because of the single drug compared to single drug. The two drugs can be better because BP is controlled by multiple hemodynamic parameters like blood volume, peripheral arterial resistance, blood stroke volume, heart rate, and other parameters. So the pharmacology should attack should be multi-pronged so that the effectivity will be more, the side effect of the drugs will be less. And in the stage 2 hypertension and more, it constitutes more than 15 to 20%. There should be always the use of more than one drug. And there is with the ARB and CCP, there is always a synergism in relation to the nitrosis, vasodilatation, and the effectivity of the drug. It has been found with the combination therapy, the composite CV outcome, the eGFR reduction, and the serious adverse reactions are much less. All are the p-value is significant in all, and there is the cardio nephroprotection with all. Synergism of the action is very, very important. The vascular protective effect, the neutral metabolic profile, the nephroprotective effect, the reduced incidence of edema, secondary to use of CCV alone, and the capacity to reduce the morbidity and the mortality in rates of hypertensive patients rather than with the RAAS inhibition and diuretic combination. In one study, it has been found with the combination therapy with hydrochlorothiazide benazepril, there was a 96% reduction. And a similar study with Temista study combination therapy, with 8 weeks, there was a significant reduction in the systolic and diastolic blood pressure. And there was 90% lowering of the incidence of edema. What happens when you do only CCV? The venous dilatation is not there, so there is fluid leakage, and that is why you get a edema because of the leakage in the capillary bed. When we use a combined CCV with a ARB, the venous dilatation is there, so the capillary leakage is less and the edema is less. Again, with a combination with amlodipine, as you see, with a 24 hours reading compared to this with 0 drugs, drug combination with 10 milligrams, you see there is a significant reduction of 24 hours hypertensive burden also in systole and diastole. So there is the control rates are around 18% in combination compared to in monotherapy is only 38 to 44%. Similar thing with moderate and severe hypertension, there is a significant reduction with combination therapy. Also in combination therapy, you see the UACR, the urine albumin creatine ratio, is also significantly reduced, and there is a reduction of the proteinuria compared to the monotherapy. And with diabetic, obesity, metabolic, elderly, and in plaque hypertension, everywhere there is a reduction of the systolic blood pressure significantly. And when it is combined, as you see, with the first 2 weeks, there is a efficient around the efficiency is around 80%. And in the next 2 weeks, another, it becomes around 47.5 millimeter mercury reduction is there with the combination therapy. So friends, with the drug therapy, we can achieve excellent control in which the RAAS inhibitors of which the ARBs and compared to the telmisartan in the today's scenario are giving excellent service to the mankind. And today we are panic with the COVID era, and in that, as you see, there is the S spike is stimulated and the angiotensin 2 receptor is stimulated, and there was an initial proposition that possibly because of the AC2 inhibition, the mortality rate was increased with the initial studies. And subsequently, it was found that the in the prospective studies, it was found that the AC2 inhibition is rather beneficial, and the mortality rate from the study is reduced with ACEI in the ARB not associated with severity and mortality of COVID-19 patients. Data support current guidelines and societal recommendations for treating hypertension should continue in the pandemic without any disturbance. So in the social media, there is some communication that they should stop. So in the retrospective study, it was also found that the ARB is beneficial, and this is a study in which it has been found that the mortality that was found ACEI or ARB 3.7 reduction of mortality compared to without ACEI ARB, it's a 9.8% mortality in that. So possibly there is no significant changes with the use of ACEI or the ARB in the process. So the European Society of Cardiology has reviewed their concept, and with a recent trial of 659 late in September, which was September the 4th, very recently they have published the primary outcome, and it has found that there is no problem, and one should not stop AC inhibitors or ARB in COVID-19 patients. So another interesting phenomena, friends, I will tell you from the behavior of the doctors in the country, in India. This was also a Ramakrishna studied way back in 2017, and in this cross-sectional study of 3 months, he found about 594 physicians and cardiologists. ARB is maximum used, and of the ARB, Telmisartan is highest use that has been found in, and it gives good control. In the combination also ARB, Telmisartan is highest in use, either in monotherapy or in combination therapy. So, friends, to sum up in brief, hypertension treatment is essential for preventive hypertension-mediated organ damage. Guidelines are many. Optimize the BP goal on individual basis with the background of guidelines, rather to the best tolerable lowest blood pressure. RAAS plays an important role in the hypertension. RAAS inhibition is an important mode to control BP numerically and also to prevent the HMOD. Of the statins, olmesartan, irbesartan, and telmisartans are more promising. And the telmisartan has the advantage of PP gamma action, prevention of HMOD, improves the vascular biology, restricts the inflammatory process with comparatively less side effects. Telmisartan alone or in combination is very effective. During COVID-19 time, do not stop ACI or ARB. It is not harmful, rather beneficial. So thank you for sparing the time with me. Thank you also the Zydus Medica team, Dr. Samir Muchala, Mr. Gautam Ghosh, Sasikant, Krishna, and the team people together giving this platform to meet you all in this evening. Thank you all. Have a very safe time in this COVID time with your family and friends. Thank you all.
Thank you, Dr. S.S. Mishra. I think it was an excellent oration. I should say it was an exhaustive presentation, that too very lucid. I'm just going through the comments, and people are really enjoying, and they are really liked your session.
Thank you, Samir. I would like to hear if anybody wants to put me a question.
Yeah, there are a few questions which have come up, so I will just post this across to you. This is Dr. Jignesh Shah from Surat. His question is, 2017 AHA-ACC guidelines suggest 130 to 139 millimeter mercury systolic, and 80 to 89 millimeter mercury diastolic as stage 1 hypertension, which is considered as high normal by 2018 ESC ESH guidelines.
Yes.
We have a discrepancy here. How does my Indian patient fit?
Oh, that's an excellent question. Dr. Shah, what has happened, you see, the Americans have become more drastic compared to the Indians and Europeans. We Indian guidelines are a little more conservative. I am a part of also that, in which we see that drastic reduction of blood pressure to less than 130, making it normal, has not become digestible by us, because though this sprint trial shows less than 120 by only systolic, they have assessed in that there is a significant reduction of blood pressure. And if you go back to the JNC 3 guidelines, in which they have studied with ATP 3, after 115 by 85, with each 20 by 10 millimeter of mercury, there each with rise of that blood pressure, there is doubling of the cardiovascular and stroke mortality. So what does that mean? That means even beyond, if we can come down to 115 even, it is beneficial. That is what has highlighted with the ACEI guideline. But the latest 2020 guideline of the IHA, means International Hypertension Guideline, which has come out very in 3-4 months back, they told went with the European guideline, or almost similar to the Indian guideline. So this is a high normal situation, but we still don't know. If you reduce less than that, possibly in the long term, the beneficial effect will come. But the one thing one has to be very alert when we are reducing anybody's blood pressure, our load. That has not been very clearly defined in the sense we have to assess each individual's what is the body tissue perfusion when you reduce the blood pressure. If somebody is well with 110 by 70 blood pressure, his brain function is well, cognitive function is well, renal function is well, possibly that is the best blood pressure. And with that, if we can maintain him, that gives a longer longevity compared to the same man maintained at a blood pressure of 120 or 25 by 85. So the discretion has to be individualized. That is why I told these guidelines are in your background. 75 years back, we are treating with cooked rice and distilled water. Today, you have good modalities and good drugs. Choose on the basis. That is why the concept of personalized medicine has come today. What does it mean? It means two individuals are not ideal. These guidelines, when they have written anywhere, they have written that the guideline is a guide. The consultant has to decide on the basis of an individual person. So, Dr. Saha from Surat, thank you for the question. I think you got back your answer.
Thank you, Dr. Mishra. Dr. Sujit Singh from Patna. He has an interesting question which is relevant to the current scenario.
Yes.
What are the medico-legal implications of managing blood pressure via teleconsultation through dependence on readings which are seen in the patients on the digital sphygmomanometer as compared to in-clinic measurement of blood pressure?
Dr. Singh, it is a very difficult question. Medical legal issues in relation to, you see, how correctly the persons are taking the home blood pressure is a very important thing. But at least any
Jignesh, has the video freezed?
Yes, sir.
Shashikant, can you call up Dr. Mishra, please?
Yes, sir.
I think there was some internet issue. I think he might log in again.
Sir, it's a net issue. They are reconnecting, sir.
No problem, no problem. Shashikant, you could speak to him?
Yeah, I spoke to him. They are reconnecting, sir. Yes.
Okay, okay, okay.
Sir is joined.
Yes, I am back.
Yeah, I think there was some internet issue.
These are all the COVID problems.
Yeah.
So, Dr. Singh, I am audible to you or not?
Yeah, you are audible.
Okay, fine. So, so far as the legal question is concerned, whether to treat a patient basing on home recording. If you are seeing the patient for the first time only on the recorded BP on the internet or the mobile, I still myself feel shaky to prescribe anything. Because unless I see the patient with a either with my digital monitor or with a dial monitor blood pressure, though the mercury pressure is still banned, sometimes I don't rely on the digital for many reasons. The digital machines, though I have been already endorsed many, like they're still not very reliable, as you know. At sometimes it is showing 180, next time 110. So depending on the quality of the machine you are using, if it is trustworthy, yes, you can go ahead. Regarding legal aspects, I don't know if we should legally treat patients on telephone, on internet, all those things. Though it has become a trend, I think there is no legal support for that.
Dr. Anjali Singh from Lucknow, she wants to know, Telmisartan is preferred in patients with type 2 diabetes due to PPAR gamma activity, which has shown beneficial effects on insulin sensitivity. Please share your views on this.
That is, I have already discussed. You see, the PPAR gamma is highest in the Telmisartan compared to the other statins. So that is why when you give a patient with, in addition to insulin sensitivity, it protects all the organs, the kidney, the heart, the vessels, everything. As you showed even with the angiographic studies with the BMS and the DES, even in the small endothelial site, it is changing. So it is good. PPRI gamma action is there and it gives the advantage. Also, it gives also advantage also in atrial fibrillation as well. There are studies, patients taking ACE inhibitor. So that is why this particular Saturn, that is Telmisartan, has played off very well after the Salim-Yusuf study after ONTARGET.
Correct.
Last 12 years. It has made excellent journey. Earlier, I was using benazepril and other drugs in 90s.
Dr. Vijay Karnik from Pune wants to know what is a better modality for monitoring blood pressure, ABPM or HBPM?
That's a excellent question. ABPM is good. It gives you the 24 hours blood pressure profile and the hypertensive burden in the 24 hours. And we can detect also patients who are deepers or non-deepers. That's a very important thing in treating hypertension. Those people are non-deepers, means the blood pressure is not reduced in the night time. They are at more cardiovascular risk. And the non-deepers are to be given the drugs in the evening time rather than in the morning time. That has a recent HGI study has that recently come, when to give the drugs. None of you have asked this question, but the drug is to be given hypertensive drug in the morning or in the night. It has to be given in the night because in the early morning from 1 a.m. to 8 a.m. we get all the cardiovascular events. Let it be stroke, let it be myocardial infarction. So to avoid that, we must, and the rise of blood pressure is in non-deepers are more from 3 to 7 p.m., 7 a.m. So in that context, I can say the ambulatory blood pressure 24 hours is good. It also unmasks your masked hypertension. When you're giving a drug and your blood pressure office chamber is 120 by 80, it goes to the office. This question was from Anjali, no?
Yeah.
Yeah. So Anjali goes to the office and the boss is angry. The blood pressure can shoot up to 180 and 190, not detected. Again, coming to the doctor in a cool mind, blood pressure is 120 by 80. So in this type of patients, the further block of the drugs are required. Maybe they may require a beta blocker or something for the surge of the blood pressure. So in this situation, the utility of ambulatory blood pressure is important. And about the ambulatory blood pressure, the home monitoring, sometimes the people having high blood pressure in the doctor's chamber, they don't have any organ damage evidence like in ECG or echo, but the blood pressure is around say 140 or 150, whether to treat or not to treat. We need time. So these people can be given a home blood pressure monitoring in the home. If the BP is around say 130 by 80 regularly, then we can wait. We can ask them for a lifestyle modification rather than jumping to drugs. That is why there is another study when the doctor sees the blood pressure, it is around 10 millimeter mercury more compared to the nurses or the pharmacists. That's a very interesting observation. So now you have to both the ambulatory BP 24 hours, home monitoring blood pressure, both has its proper prospects in the how you use it.
Okay. Dr. H. Rajashekhar from Belgaum. His question is, which ARB is having the maximum data with respect to beneficial effects on target organ damage? And that's it. That's what the question is.
Dr. Rajsekhar, you must have gone through my lecture. I have already projected you comparing all the Saturns together. Telmisartan has shown the highest benefit. No controversy on that.
Right. The last question what I can see is from Dr. Shantanu Roy. Again, you have discussed this, but it's my duty to ask you. He's from Kolkata. What is the recent stand of RAAS inhibitors in the management of hypertension in the current COVID era?
Okay, Shantanu, possibly I missed my last part of my lecture. Well, the controversy came in the early part of the COVID time in February. In the NEGM, there was a publication and suggestion from a professor from Wuhan that the 82 receptors are stimulated and that increases the mortality and morbidity. But subsequently, at that time in March, all the associations, they also deferred that we should not stop this drug and continue this. And by the September, even on October, in May study and also in September, we have concluded that there is a beneficial effect rather than harmful effect. I think I give you the answer correctly.
Sure. There's one more question which has come up that a couple of years back, there was a term called as lipitension, right? So how clinically relevant is this term in the Indian scenario, lipitension?
Lipitension.
Yes.
I don't get it. What does she mean?
I think it should be dyslipidemia and hypertension as comorbidities.
I see. Oh, so this type of like the diabetes and obesity, they are putting that together. Okay. It has a point to think. You see, any patient who is having hypertension, as I told you, there is endothelial damage. Even hypertension alone can progress the atherosclerosis. Even your lipid level is normal. You are a euglycemic person. Just because of the sheer stress and the inflammatory process in the hypertension, atherosclerosis is always in progress. And when the additional factor like lipid is there, so there are two persons to damage the cardiovascular system, the kidney, every organ, because the atherosclerotic process is enhanced. So your lipitation or the other friend like diabetes, also people have coined with uh, glycitension. All these concepts are combinations only. So they go together. You see, the relevance is that we have to be conscious.
Okay, great. So I think we have come to the end of the questions that we have got from the audience. Before I would propose the vote of thanks, I would like you to give the key take-home messages from your end.
I've already given at the end. Further.
Yeah.
Okay. So far as India is concerned, friends, first thing, as I told, we are having a seminar, the gap in treatment of hypertension today, in particularly in India. First thing is detection. The detection in our country is poor because it is a silent killer. Nobody checks their blood pressure. Second thing, people come to those who are conscious, they come to the chamber of a doctor, show the arm like this. Doctor, check my BP. This annoys the young persons or anybody for that reason. When instead of a proper consultation, they ask for just check the BP. It irritates possibly the mind of the consultant. This is what I have found because I have seen consultants referring with a normal blood pressure for other reasons, the blood pressure is high. They are very knowledgeable persons. Why do they miss this? The reason is they don't go above 160, 170 or 180 blood pressure to see that there is a upper limit of the blood pressure. If you go to 140 and reduce the blood pressure, you could give a recording always 130 by 80. So it is important that when you check a blood pressure, always increase to 250, or you always check a palpatory method of the blood pressure before going for stamping somebody as a hypertensive. After that, take a routine blood pressure. Check the blood pressure in a cool mode as a consultant. The patient should be in a cool situation. So detection in our country is a very important factor, which need a cooperation from the patient side, also the cool mind of the doctor as well. And this is a very important thing that BP recording itself is a detection of a disease. The investigation which immediately promotes you to treat, not like a ECG. You take a ECG, it doesn't give you any answer to treat anything. ECG may be normal, having a normal myocardial infarction which has not come up. So a blood pressure always decides for your treatment. So take a proper thing. So detection has to be proper. Second thing, when you treat with a drugs, ask them they have to take it lifelong. And the dose has to be monitored from time to time by the consultant. The dose is not fixed because your body physiology is changing from day to day and time to time. The dose has to be adjusted. Maybe today it is a high, it Telmisartan 80 milligram, tomorrow you require 40. Again, after some time you may require a 60 milligram with a diuretic. So all these things has to be adjusted from time to time. Third thing, the dose adjustment and the adherence rate. People, they should be taught about adherence to the treatment. You will be surprised even in USA, like where education level is high, adherence is only 45%. And in India, adherence, as we have studied, is only 14%. So you are detected hypertensive. When you feel better, you stop the drugs yourself. Then go to Unani, homeopathy, naturopathy, other pathies, and land up and come with a sudden hypertension of 220 by 100 blood pressure with a stroke. So friends, always emphasize that the blood pressure is a lifelong problem. There will be fluctuation of blood pressure from time to time and the dosage of your treatment. And the treatment has to be lifelong.
Thank you, Dr. Shishu Shankar Mishra. I think that was great take-home messages. We had great deliberations on various aspects of RAAS inhibition in hypertension, especially in the context of recent guidelines and target organ damage. I thank you very much for an excellent oration and for navigating the discussion in such a way that our delegates have got a very clear take-home message. I am really happy to share with you that we had 514 doctors who have witnessed this webinar today. I thank you all for your precious time, for coming on this webinar on a Saturday evening, which is supposed to be family time, and also for supporting our Indian patients during this real COVID scare. Hats off to you. Thank you very much, Dr. S.S. Mishra again. Let us stay indoors, stay safe, stay healthy, and may God bless each one of us. Thank you very much.